a warm welcome to our coverage of this year's ASCO Congress. ASCO is one of the largest cancer congresses organized by the American Society of Clinical Oncology. My name is Alexandra von Korff, and on behalf of Patient in Today and Mamma Mia, I would like to warmly welcome Professor Sherko Kümmel, who has kindly agreed to join us today to walk through the studies we've selected, those we found to be the most relevant from a patient's perspective. Sherko, would you like to briefly introduce yourself or just dive right in?
So, dear Alexandra, first of all, thank you again in advance for the invitation to reflect a bit on everything today for you and to see where we might be able to question or do certain steps differently, maybe as soon as Monday, etc. In all of this, my name is Sherko Kümmel. I head the breast center for women at the Essen-Mitte clinics, which is, as the name Essen already suggests, in the western part of Germany. Beautiful, the state of North Rhine-Westphalia, something you eventually get to know and appreciate as a Berliner as well in this situation. And at the same time, my second role, so to speak, is that I am also one of the scientific directors on a full-time basis in the WSG study group. Many people know this from the ADAPT studies, etc., where there were also some news updates at ASCO regarding all of this. So that's basically what I do every day. What that means is I actually spend, well, my family would say almost 24/7 dealing with the treatment of breast cancer or with treatment options. So with that, let's get started right away with what we heard at this year's American Cancer Congress. I can already say in advance, you've already heard about other things also in the metastatic, more advanced setting, about how much progress has been made. In recent years, we would come back and it was always nothing new in the West. That's a familiar title for us in all of this. But today, we have to say a lot has happened. A lot happened in these two main sessions things that on Monday we might either see confirmed, things we've always suspected or done, or perhaps realize we should change something. That's the disclaimer for all of this. And also my conflicts of interest, that is my disclosures regarding all the roles I have in this context. And now we come to the question at the heart of it all, adjuvant endocrine therapy. And when I explain endocrine therapy to my patient, we all wonder, what exactly is he trying to say? If I then clarify that it's not just endocrine therapy, we call it that broadly, but actually anti-hormone therapy, it becomes a bit more concrete. Of course, that can also cause some hesitation. Rightly, women say, oh God, what does this mean for me? Will it be as I expect, flashes, sweating, mood swings, bone pain to name, just some of the complex symptoms that can occur? You have to prepare them. And I tell them up front that there's always some new medication coming out. If it's shown to be very effective and gets published in the New England Journal of Medicine, which is the highest level of publication, it becomes widely known and everyone expects it to change the standard of care. That's what we call practice changing in this context. And now there was, and I'm mentioning this in advance, an improvement in side effects with a new medication in all of this, which is also being published in the New England Journal, because it's the first time this study has been presented. And it was about the so-called OASIS study. Sometimes there are such fitting names that people come up with. And bear with me, we first have to get used to this elinzanetant, so to speak. I don't know if you can pronounce it without mistakes. I hope that soon in a lecture I'll somehow manage it in English as well. Some people just try to. It will be exactly. That's the reason why people love and live medicine with such persistence, because then, so to speak, you don't constantly trip over it, because whoever comes up with these names, I have to say, for me, personally, I come from the time when people got to know OASIS. So with all of that, with the study name, you could make sense of it, but whoever, I'll just say, comes up with drug names or the names of medications, well, let's just say there's still room for improvement in the whole situation, but let's not get stuck on the names. The real question is what actually happened in this situation. So we included women who had 35 hot flashes per week, that's about 5 a day, which was the requirement to participate in the study. Of course, no one checked if a woman who said she had 5 hot flashes had fewer, the numbers weren't verified. But that means anyone who volunteered was suffering from hot flashes severely enough that it was important to them. This was a placebo-controlled study, meaning participants either received the medication or they didn't, so to speak. The medication was taken by women, making this the first study in this field involving hormone receptor positive breast cancer. Now, some might say, wait a minute, that's not true what he's saying about the New England Journal. And that name, that's impossible to pronounce. After all, we have Veosa as an example in all of this. That's correct. But the study with Veosa was never conducted on breast cancer patients. It focused on hot flashes. Hot flashes that, for example, can be triggered by so-called anti-hormone or endocrine therapy were not examined in that study. Instead, it looked at hot flashes that naturally occur during menopause. That's really
exactly. You're put into menopause
good.
Artificially. And with that, you get the whole range of side effects, sometimes more, sometimes less. And of course, unlike women without breast cancer, you can't receive the hormones that are normally used to treat these symptoms during natural menopause. And then it's often just like, well, too bad. You'll just have to deal with it.
Yes, exactly. That's how it is in all of this. So in that respect, we still don't know about Veosa. Studies on that are about to start soon, including one in Germany. So you can already start looking into that. That will be starting soon this summer or shortly after at various centers in this context. Why? And that's what we're going to take a look at now in this situation. That means overall, the patients were treated for 1 year. They looked into it. It was randomized. So one group of patients received the medication immediately and another group received it during the first 12 weeks. A placebo in the whole thing in this context. And after the 12 weeks, all patients received the medication in this situation. And the primary endpoints were, of course, the change in the frequency of hot flashes overall, measured at various time points after 1 month, after 3 months, and so on. In this context, so how was it in terms of reduction, so to speak? These are now tables. Let me take a look. I'd rather show a graphic for this. And from that, you can see the main messages of this study and why it also made it into the Journal of Medicine. The first point is, some people might say, the upper curve is placebo. Using a placebo and paying attention, something happens. That's simply a placebo effect. But secondly, if I give the actual medication, the effect is much greater. The reduction in hot flashes. And that is highly significant. The third message, and this is absolutely crucial, is that this effect sets in immediately. So after 1 or 2 weeks, you can see this is the drop, the downward trend of the curves. And when after 12 weeks, the other patients also received the new medication, they eventually experienced it as well. By, let's say, week 22 to 24, of course, that's a few months later, they reached the same threshold of hot flash reduction as the patients who received it from the very beginning. In this situation, these are important messages. So I start therapy and relatively quickly, women experience symptom improvement. They no longer have to change their bed linens or pajamas 3 times a night or find themselves suddenly soaking wet, whether at home or at work, as they describe. This is highly significant, meaning it meaningfully reduces symptoms. This VMS, when everyone asks, what does that mean? Vasomotor symptoms is the Anglo-American term for these hot flashes in this context. So for me, it's practice changing. Now he says, okay, I want it prescribed by Monday. We have this will certainly be submitted for approval. So for me, the bottom line of this study is very clear in this situation. If it becomes prescribable, then the study results are sufficient for me. From that point on, I would also make it available to patients who suffer from it. So that means prescribing it in general.
Could you please give us a quick outlook? I think it is already under review for approval, isn't it? So it might not be too far off, or am I mistaken about that?
Well, even if it exists, it depends on how the authorities will ultimately decide how it will be introduced. Sometimes there is a fast-track process, yes, in urgent situations. So if that is applied, i.e. as a fast-track procedure, I think we will probably have to wait half a year to a year to answer your question until we can prescribe it.
Fingers crossed. Who knows?
Let's keep our fingers crossed. But honestly, it doesn't really matter. For the first time, we now have a medication. We can always, of course, have a separate discussion at some point about what else we have available. But here, these so-called neurokinin 1 and 3 inhibitors really do seem to be highly effective. That's the story behind it. You no longer have to take duloxetine, which does have significantly more side effects. Also, are you referring to acupuncture or perhaps anything else? Based on the current available data, what would now be considered the new standard for significantly reducing the frequency of hot flashes for those who regularly suffer from them? Side effects, since it is a medication that also acts on the central nervous system, meaning it essentially binds in the brain and exerts its effects there, include drowsiness and fatigue in situations attributed to the medication, so to speak. That's what is attributed to it.
That brings me straight to my next question. Many patients also suffer from insomnia as a side effect of anti-hormone therapy. So if they suddenly experience fatigue now, does that mean it also works against insomnia? Or are we talking about two completely different problems that just happen to occur?
Well, we are only allowed to talk about hypothetical cases anyway. It could be that I have patients who are already taking another medication because they simply say, I have so many hot flashes, I don't care, even if there isn't a study on it. I pay for it myself and I take it. I haven't really seen that yet. You always have to look, I always think the quality of sleep is very important. It's not just about being completely exhausted but still unable to sleep. It's a bit more nuanced than that. So insomnia, as it's called, sometimes you really have to address it a bit more closely. And I think it makes a lot of sense to use different approaches, including those from integrative oncology. That means meditation, yoga, various things, even lavender remedies. So all these questions require a bit more in-depth consideration in order to maybe, and I would say nowadays we have all the tools, smartwatches, for example, without naming any brands, which you would rightly criticize me for or what doesn't work. Smartwatches already give us so many options these days, like tracking our sleep, monitoring it, seeing how we're doing, what our sleep frequencies mean, what the different sleep phases mean. And I can even discuss this with my doctor and so on. We have these possibilities now, and I would definitely make use of them, I think. And if we then, you're right, if we then get to the point where tiredness leads to an improvement in my sleep quality, then I've achieved a lot. Sleep is a quality of life. And
yes, sleep deprivation is a form of
therefore,
torture.
Sleep deprivation is the greatest torture and has to do with longevity. Very important point.
Yes.
For me, the takeaway from the study, as we've already mentioned, is that if it gets approved, it will definitely be something that should be integrated into everyday treatment. Some people might say, yes, but what do I do now? On Monday, I have these hot flashes every day. There will be a study with another medication that already exists, but not yet for breast cancer patients. Of course, people say, yes, but if I get the placebo, then I have almost a 100% chance of not getting it. In the study, I might have a 50% chance of getting it in that situation. It's another medication where today we can probably assume that we will also see effectiveness because simply the class of substances has already been used once in non-breast cancer patients with one medication and now in breast cancer patients. Both studies have each shown a highly significant reduction in hot flashes.
Wonderful. Thank you so much. These are truly groundbreaking, as you nicely put it, practice-changing news. And I think there's a lot of suffering behind all of this. So this really feels like a ray of hope now that it's becoming available. Really great thanks for all the information and the helpful tips.
Pleasure.
Let's move on to the next study.
So then let's move on to the question now. We're back to it. As some of you who have been following along know, we've often talked about de-escalation. Now we're going to talk a bit about escalation. That means how can we contribute even more to hopefully preventing a recurrence, so to speak, or ensuring that no recurrence occurs, in other words, that breast cancer does not return at all. That means in addition to the typical anti-hormone medications in younger women pre-menopausal, i.e. before menopause, we are talking about additionally that means starting a suppression of ovarian function. This refers to the injection that can be given every 3 months when taking tamoxifen or under aromatase inhibitors, which I mentioned because there are always questions about this. It's usually given monthly. So for example, this Zoladex injection in this situation. And that's where we talk about the data. And here we have to say we now have these soft and tech studies, which we've already examined countless times and in numerous publications. And now we have 15-year data on all of this. That's always important because just last week I had patients who came in with exactly this kind of question after 10 years. Is there still something I can do about it? And in this regard, we can actually discuss with patients in various ways exactly where we stand. And I think you can summarize this study relatively well. Several thousand patients were randomized to tamoxifen versus aromatase inhibitors. Here, for example, exemestane is always used as an example, or tamoxifen with ovarian suppression or the aromatase inhibitor. With the oval suppression, they compared options again, tamoxifen with ovarian function suppression, or aromatase inhibitor, always with ovarian function suppression. They forgot to include aromatase inhibitor alone. That's exactly why I say you really must not do that in young women, so to speak. An aromatase inhibitor alone, when used in premenopausal women, simply would not be sufficiently effective. That means if you prescribe an aromatase inhibitor in premenopausal women, you have to do it together with ovarian function suppression. In other words, there is no arm with aromatase inhibitor alone. That is only for patients in postmenopause, where you don't need to suppress ovarian function. You don't have to suppress it there. So now let's take a look at this. And this is a slide not from ASCO, so to speak, but rather from the discussion from Michael Gnant from Austria. In all of this, who once again simply showed us quite clearly what was already known after 10 years. After 10 years, it was known that these patients who had a low risk, for example, no chemotherapy, low biological risk, meaning based on the tumor's risk profile, did not need ovarian suppression. They received enough benefit from tamoxifen alone, but as soon as we have a slightly higher or intermediate risk, so more lymph node involvement, larger tumor, grading, meaning higher grading or higher oncotype, all the different patterns we have today. We would also include things like Ki-67 not responding as well, what would be considered as induction therapy back then. This wasn't as widespread internationally. These are the kinds of patients, just to describe, that I see today with intermediate or higher risk. Where you can then see and hear, the curve is actually the other way around when you add ovarian suppression to the treatment. With this injection, you get a significant improvement, meaning that fewer recurrences occur overall, which is a positive result for patients. Endpoints of the study, again, disease-free survival overall, various endpoints. That is, of course, the crucial factor here. That means, am I actually saving additional women? If I use this therapy, which does mean more toxicity, more side effects. But am I unfortunately accepting these side effects in exchange for higher effect? That's the key question. Only then are more side effects justified overall. So let's take a look at that. I'll pull up the curves. It's easier to see that way. Overall, you can see that even after 15 years, a medium or high risk of recurrence is confirmed. There is a benefit in treatment. Women have an advantage if, in addition to the standard strategies, an ovarian suppression is added. That's what it's called, meaning a suppression of ovarian function. Yes, in the whole context. A very important question. And now comes, by the way, just last week, I had a patient who asked exactly this question. What about patients who didn't have such a high risk? And there you can see that in terms of survival, there is no difference for those patients, only a small prophylactic effect for a slight effect on the other side. So the tendency is rather not to treat, because, of course, suppressing ovarian function also has side effects. Not just bone pain, hot flashes, and intensified menopausal symptoms, because you are immediately put into menopause chemically, but also long-term osteoporosis. It's always important to me that people remember to ensure women are well treated throughout the whole process. Because it's no use, survival rates are getting better and better, but if, so to speak, bones start breaking at an older age, that's not really what we want to achieve either. And the additional fracture rate is already significantly increased in all of this by a few percent, which, for example, can be noticeably reduced by combining with bisphosphonates. So that's something that should be considered as part of the overall picture. That's what the study has shown once again. And now we also have long-term data on this. A result over 15 years is truly a long-term outcome. So in summary, there is now long-term data showing that women with higher or even moderate risk of recurrence benefit from the additional suppression of ovarian function.
Yes, and at the same time, it shows that in the early stages, it's simply not necessary. You really only need to do it in specific cases. That in itself is a kind of de-escalation. So if a patient comes in and says, I know I'm low risk, but I still want my ovaries suppressed just to be on the safe side, you can point to this data and say, no, that's really not needed. To be honest, we really don't
Exactly.
need that.
Many
In
patients
this
have been
case,
treated, and you're right, it's not always necessary.
yes, that's exactly why. I think when you have to accept all those side effects, you really want to know what you're doing it for. What about the side effects? What's your take on that?
Yes, they already are. So I would say, since we are increasingly moving in that direction, because now you have to say all women who now, so to speak, have a medium or high risk are getting another escalation on top of that. So ovarian function suppression and CDK4, 6 inhibitors, meaning ribociclib or abemaciclib.
That's quite substantial.
That's something that really needs to be said right now. It truly is a form of escalation, but with each step, you gain several additional percentage points in survival.
Yeah.
In that situation, that's why I would always say, always start with everything. You can always stop if it becomes unbearable. But if you never start, you'll never know, never truly know whether it might have in reality genuinely ever been possible in the first place. And by doing so, you also deny yourself this higher effectiveness, so to speak, if you say, I'm not going to do any of it based on everything you've read and heard. And whatever else you might have.
Or to weigh things up on an individual basis, as you just said. Maybe it's actually better not to suppress ovarian function, but instead to consider bisphosphonates for bone health. It's about looking at the whole picture. I thought that was a really interesting aspect to keep in mind.
Yes, and you always have to say, I always tell my patients when they say, I've read so many terrible things about it, I always say, just imagine, if you don't have anything now, I also have patients who have few side effects. If I were to ask you tonight, let's add a bit of sunshine, please sit down at your computer and write, I'm feeling fine. Would you do it? No. You see, that's the difference. That, of course, there are many who have a path of suffering, which is also there in the whole thing. Of course, they look for help, seek it out, and as I said, write about it, etc. That means the perception is always more negative than it actually is. That always needs to be pointed out, because we ourselves tend to not to express the positive things very often, or to write them down in all of this. That's why there's a bias in there as well.
It always depends. Some people say, let's just focus on the positives. So it really goes both ways. I get it. The thing is, what really sticks with people are the stories about severe side effects. And of course, those experiences are real. There are people who truly suffer sometimes very, very deeply.
But we are still
underneath it all.
so easily triggered. I don't even want to get into that whole eavesdropping discussion now. We could do a little test, Alexander. We could ask ourselves, when was the last time we watched the news and saw something positive?
Yes, that's a really good example.
When was there a message where you thought, great, that was great, people successfully accomplished that today, and that was really unique in relative terms? We're already raised in such a way that which is of course right, that we inform ourselves and so on. And of course, the difficult news takes up a large part of the frame there.
Yes, I think it's an important message from you to say, just because you've heard that something affects others a certain way doesn't mean it'll be the same for you. Everyone's different, and everyone tolerates things differently. We'll try it, and if it really doesn't work, then we'll stop.
You can stop always.
Exactly. That's always an option. So thank you for that. It's clear that there are quite a few new possibilities opening up here.
Gladly.
Let's move on to the next study.
So, and now we come to the point as if we had anticipated it. The next escalation, the abemaciclib, that is, the so-called CDK4, 6 inhibitor. For many, that's already basically standard now.
Would you mind explaining that once more? I believe it's a concept that's more familiar in metastatic cases.
So what is a CDK4/6 inhibitor? The name says it inhibits CDK4 and CDK6 in this situation. What are those? Here comes biology class again. And our teachers were right. There's this cell cycle, which of course doesn't run in a circle, but it's like, you remember there's a G phase, M phase, S phase, and so on throughout the whole thing. That is the replication of the cell, so to speak. And in this cycle, there are various enzymes and mechanisms which, when they are inhibited, of course, cause the cell to be unable to replicate itself. And which cells like to replicate especially often and more than others? Those are the cancer cells in this situation. So CDK4/6 inhibition works through this mechanism, meaning that an above average number of cancer cells, for example, are, let's say, destroyed in this situation. The data shows that this means it is the standard in a metastatic situation and, for example, was better than chemotherapy in comparison. And in the adjuvant setting, meaning in early stage disease, which is what we are both discussing today, it is often standard after chemotherapy for patients to additionally use abemaciclib alongside anti-hormone therapy, that is endocrine therapy. Here, abemaciclib is given for 2 years in this situation. Of course, usually for young women, ovarian function suppression, always aromatase inhibitors or tamoxifen both are possible with abemaciclib. And then abemaciclib, or in postmenopausal women, also aromatase inhibitors plus abemaciclib in the whole regimen. And what kind of side effects can it cause? We all know about these so-called gastrointestinal symptoms. What are those? Gastrointestinal complaints in simpler terms, a rumbling stomach, stomach cramps, all the way to diarrhea, which of course can also reduce quality of life. And so to speak, it should be recognized as early as possible and then treated prophylactically and relatively quickly with Imodium, that is loperamide, yes, in that situation. In the whole context, now there was a study, it sounds quite simple. In the whole context, that means they simply did an escalation with a tablet taken over 2 years. Actually, that doesn't quite describe it accurately. Instead, they started with a lower dose and gradually increased this dose over the first 4 weeks. The recommended dose in the end is 150 milligrams, so to speak, twice a day. So at the beginning, they started with a lower dose, then increased to 100 and then to 150. And after 12 weeks, they looked at how many patients, for example, dropped out due to diarrhea and so on throughout the whole process. This is, so to speak, the trade study. They took a standard concept and modified it a bit. Whether you reduce the dose during the first few weeks, say, you lower the dose, what you then take for 2 years, that doesn't significantly affect overall effectiveness at all. No doctor really asks whether it's less effective if in this situation you have a slightly lower total dose during the first few weeks. A low starting dose nicely shown here by the team, 50 milligrams twice daily for 2 weeks. Then from week 2 to 4, increased to 100 milligrams. The goal was tolerability or slow dose titration. Does this, for example, lead to less diarrhea or fewer dropouts? This was measured after 12 weeks. There was the large study that led to the approval of this medication because it showed a survival benefit, the MONARCH study. And that study was used as a comparison group in this situation. And here, so to speak, are the results. 70% continued this therapy at 150 milligrams after 12 weeks. In this situation, in comparison, in the MONARCH study where they started directly at 150 milligrams, after 12 weeks, only 60% continued. So just by gradually increasing the dose, I had 10% more patients who tolerated it better. This is the translation of this study. For me, that immediately means a kind of practice-changing approach that I can apply on Monday. And maybe again, I can identify a few patients who won't discontinue the medication because they say they can't handle it, that it causes too many side effects overall. So that means, in my view, it's an important study because it enriches our daily therapeutic practice since we can make things a bit better again. So those were the results once again. I think, or rather, I believe the most important point is this. This 10% difference between the comparison group and the MONARCH study in terms of reduced diarrhea in this context, anyone can look that up. That's basically the takeaway. And actually, as always, we learn a lesson from it. Somewhere things move more slowly. We also knew it from lapatinib as an example. If I titrate a bit more slowly, then I have success, especially when it comes to issues like gastrointestinal complaints, diarrhea, and so on. So really, it's a very logical and classic concept that has also led to success here. What does that mean for us for the treatment approach? That's why my summary, as I already mentioned, a simple study that can be adopted in everyday clinical practice with stepwise dose escalation, because you start at a low dose within 4 weeks during therapy initiation. This can now be considered for every patient.
Yes, I think it's fantastic. In the end, you tend to think, even in everyday life, it's like that with anything new you try. If I go from 0 to 100 right away, like saying, I'm going to work out 3 hours every day at the gym, then I also know how long I'll actually keep that up. But if I increase slowly, well, that's basically what the study has shown.
Yes, and on the 3rd day, I don't go to the gym because I can barely move anymore.
Exactly,
because it's just
right.
pain, yeah.
And if you start slowly, it works. And like you said, I don't know, this probably wasn't shown in the study because, as you mentioned, medically it's considered over 2 years or 3 or 4. So it probably doesn't make a big difference whether the treatment was a bit reduced at the start. But has anything been proven about that?
No. So if I, now you're right about that, but if I just see that maybe 10% more patients stay on the therapy
Yes.
longer, then I would even see the effect of better survival. But I'm not allowed to do that again. I'd have to test it against placebo again in that situation. First of all, that's not ethical because we already know it has a survival benefit. And if I already know that 10% do better, it's better tolerated after 12 weeks. If I now compare it again with the standard dose, I won't find it either ethically, because I believe that whether I save a few milligrams over 4 weeks doesn't have a significant impact over 2 years.
I'm thinking especially of very anxious patients who might say, to be honest, even if the risk lowers my survival chances by just 1%, that feels too risky for me. I believe with that in mind, it's definitely something you can talk through with your doctor, whether you decide, yeah, that really works for me and that's the path I want to take.
There are also analyses, but of course, these are all not randomized studies in the evaluation, but rather exploratory analyses, meaning that you look at it again retrospectively, so to speak. Or retrospectively, if it hadn't even occurred to you before and you analyze it again, then these show, for example, if you started with 150 and have to continue with 100, even if you reduce the dose due to side effects, the effectiveness is still there. So I don't think anything will happen because of that, period.
But that's a great databases to make such decisions. Wonderful. Thank you so much. This comes from the topic on hormone receptor positive breast cancer, early breast cancer, the last study we presented. Thank you very much, Sherko, for your time and for explaining everything so clearly and for joining the discussion. I'm looking forward to the next recording. Thanks again so much.
With pleasure.